There is a 50% chance of developing post-inflammatory hyperpigmentation despite prepping the skin.
And the main aim of this talk is to prevent and manage complications for you. And this will involve us talking about a pre-procedure, prophylaxis in certain patients, how to reduce risk during the procedure, correct dosing, and also what to expect and prepare the patients for during the post-procedure aftercare. This is meant to be an easy reference guide for preventing and recognizing and managing complications after fully ablative or erbium YAG or CO2 facial resurfacing. And as I said, it's been built from expert consensus statements plus supporting trials and product labeling. It isn't a mandate, it isn't clinical judgment, and it doesn't take into account individual patient factors. So those factors do supersede any advice, and really you do need to try to apply the guidelines to your individual cases. Where this evidence is soft is that the two consensus statements that from Kang and Levy back in 2025 do not agree on everything. They didn't agree a consensus on bacterial agents and, for example, whether you use them routinely and which antibiotic to use. So there are 6 decisions you need to take in order to choose to perform a successful treatment and have a great outcome. First of all, easy. Who should not be treated and who needs extra caution? So first of all, just because a patient wants fully ablative, full field, CO2 laser resurfacing does not mean that it's the right thing for them. They may have false expectations of recovery, of downtime, and of results possible. They may be unaware of the risks involved. They may be unaware of the significant psychological impact that the procedure will have, the fear of not looking normal again, the fear, the regret. People around them at home will be concerned not only whether or not their friend or loved one will return back to normal, but they might also be questioning their mental health to proceed in such an extreme procedure. So all of this needs to be discussed during the consultation. We need to understand their medical history, and we also need to understand their drug history and any psychological history that they may have. Anyone with a history of various chronic autoimmune dermatological conditions such as sarcoid, we need to be aware because that can have an impact on their healing process. If they have pets at home that molt, such as dogs or cats, that is an infection risk during the recovery period, and we need to ask them to take measures to minimize contact with those animals and preferably avoid them completely. They should also give their house a deep clean before the procedure so that they come back to a clean house with no contaminants there already. Now, patients who, for a living, dog walk or look after horses, you're going to have to ask them to make alternative arrangements for at least a week and possibly 12 days. This is non-negotiable for obvious reasons. The contamination from dust environments, from excess sun exposure is key. Now, we can minimize the risk of infection with good prophylaxis. They must be put on antiviral prophylactic agents. I do also tend to put them on antibacterial prophylaxis. I don't routinely use antifungal unless they have a history of repetitive candidiasis, and also if they are of a darker skin type, I will also give them prophylaxis hydroquinone for probably 4 to 6 weeks before the procedure. Regarding the dose, we need to choose what's appropriate. So in a Caucasian skin type, we are able to go for higher strong settings, and in a darker skin type, obviously we need to be gentler or at least colder. When I say colder, that I mean a shorter pulse duration such as on the Erbium YAG, maybe 100 microseconds for full ablation. Downside of that is that it does mean you are going to need to do repeated passes, and therefore you need to manage the pain better. Treatment. During the procedure, it's important to document the treatment parameters on the different regions of the face you're using, and preferably have the assistant do that for you. It's important also to document what you've applied on the skin before afterwards as well. Now, in terms of aftercare, the healing period, the most important thing here is to use a moist occlusive ointment. Now, that can be simple petroleum jelly or Aquaphor, and they're going to need to use this as often as it takes to stop the skin drying out. In between those periods, they can use vinegar, diluted vinegar soaks, which will help sterilize the area, clean the area, and reduce the risk of bacterial infection. And then they reapply the occlusion ointment. If the patient is experiencing worsening pain in the first 48 hours, you need to see them. This could indicate infection. If there is any concern with patient eyesight, again, you need to see them straight away. After 48 to 72 hours, the exudate should be starting to become darker from yellow. So initially it had been yellow, it should be going darker and drying out. If it's still purulent and turning green, I suspect a secondary infection. You may need to consider changing the antibiotics, and you may also need to consider adding in an antifungal agent. Do not delay. I'd rather you were overcautious than trying to get away with not prescribing any drugs, because the quicker the recovery, the reduced risk of post-inflammatory hyperpigmentation and scarring, and obviously at the end of the day, a happier patient. So this is what's expected. There will no doubt be transient erythema and swelling and serous drainage and occasionally acneiform eruption. This is normal, and you can expect the patients to all comment on this. Erythema beyond 4 months is a complication. It could be because of the laser, it could be because of the home care they are using as well, and it could be because of their skin hypersensitivities. Delayed or permanent hypopigmentation is a difficult condition to manage, and I would ask one of our dermatologists to review that situation. Post-inflammatory hyperpigmentation should largely be prevented with hydroquinone pre-op. If you are concerned about its developing in a darker skin type, or even some skin types 3 and 4, I would use Dermovate for the first 2 days after the procedure. This has been shown in some of the consensus statements to help reduce the risk of post-inflammatory hyperpigmentation. But it should also be understood that the most common complication with laser resurfacing is post-inflammatory hyperpigmentation, occurring in between 40 and 50% of cases. We've talked about infection and scarring already. Absolute contraindications before treatment are obviously an active local skin infection, personal history of vitiligo, and any allergies to any of the drugs and alternatives cannot be found, as well as an unfavorable psychological profile such as body dysmorphic disorder. If there's a history of keloid, we need to understand where, how long ago, what was the trauma, and I still wouldn't treat someone if they've got an infection elsewhere, just to make sure. Obviously, the higher the Fitzpatrick, the higher the risk of PIH, and therefore use the hydroquinone protocol with the Dermovate protocol, and as suggested in the earlier slides. So let's go back with the 4 pillars of prophylaxis. Antiviral, every full case. Antibacterial, the evidence suggests only risk-based and those with a strong risk of MRSA or poorly controlled diabetes. Antifungal, there's a small indication for that. That's for people with a recurrent mucocutaneous yeast infection, and routine prophylaxis is not recommended. And pigment, every patient should be considered this. Now, they should be on strict sun avoidance and daily broad spectrum sunscreen for at least 30 days beforehand. And for darker skin types, a topical lightening regimen should be considered, and I would prefer you prescribe hydroquinone 4%. So everyone gets antiviral prophylaxis regardless of if they have an HSV history. Start it 12 to 24 hours pre-op, preferably a day before, and carry on until they've completely re-epithelialized, which is typically about 5 to 7 days. So I'm happy for you to start them on a 10-day course, and this has been supported by randomized controlled trials as well. Valaciclovir is the preferred choice. You can also choose famciclovir as well as aciclovir. There doesn't seem to be too much difference in the efficacy on the results. So valaciclovir is 500 milligrams orally twice a day, and aciclovir is 400 to 800 milligrams twice a day. If there's any renal disease, please adjust the dose accordingly. High-dose valaciclovir has been associated with TTP and HUS in severely immunocompromised patients, but this is not expected at prophylactic doses, but do keep that in mind. Why valaciclovir has been shown is that the protocol reports a near 100% prevention of HSV reactivation in facial resurfacing. So that is probably your safest bet. It is a prodrug of aciclovir, and it has substantially higher oral bioavailability, which allows for effective twice-daily dosing and better adherence, which is the real-world reason why it's preferred. What about the antibacterial? There is no consensus. Obviously, if there's a higher risk of MRSA, and we don't routinely swab our patients for MRSA, or if there's a risk of frequent skin infection, or if they have poor controlled diabetes, these are definite indications. But the consensus really doesn't come to an agreement on which antibacterial agent to use, and Kang prefers it to be used for high-risk only patients. Agent which seems to be the most popular amongst the consensus studies was 100 milligrams of doxycycline orally. Start it the day before the procedure or the day of the procedure, and just take it for 7 days. That seems to do enough for most patients. Alternatively, you can use cefalexin. Again, you start it between 1 to 3 days before and continue for 7 days afterwards. Kang suggested 7 days in total. If there is an MRSA risk, you can use intranasally mupirocin and start that 3 days pre-op and continue until the skin's recovered. And if there is a risk of yeast infection, I would probably prescribe them fluconazole 150 milligrams once on the day of treatment. Doxycycline's used mainly because of its anti-inflammatory action, which is potentially useful in inflamed ablated skin during remodeling. It's also familiar in acne management with activity against Clostridium acnes, and therefore will help prevent the risk of acneiform eruption. It's inexpensive, it's widely available, and it's very simple for patients to use. Now let's talk about how to prevent hyperpigmentation. It all starts at 4 weeks beforehand. We need to make sure that everyone is using a broad spectrum sunscreen for at least 4 weeks pre-op every day, and I would suggest twice a day. They need to continue this for at least 4 months afterwards. And then I would also recommend prescribing hydroquinone with or without Klickmann's formula, applied nightly. Hydroquinone is generally enough. Start around 4 weeks pre-op. You can stop 4 to 14 days before the procedure. So that, in other words, they need to be on it for at least 2 weeks beforehand. and particularly relevant in the darker skin types. What a lot of people miss is that the lightening regimen is stopped 4 to 14 days before the procedure, but not continued into it, while photoprotection continues and uninterrupted through the treatment and for months afterwards. After the laser treatment, you can use triamcinolone 0.2% cream, but that's quite difficult to find here in the UK. But what is easy to find and is relatively cheap and straightforward for patients to get from pharmacists is clobetasol propionate, otherwise Dermavate. A short course, you start it 2 days post-op and carry on for the next 5 days. Oral tranexamic acid, 250 milligrams orally, 2 to 3 times a day for about 5 days. You could use intradermal tranexamic acid injections. This has been shown to be the highest in a network meta-analysis, but bruising and discomfort may occur. I would probably stick to Dermavate or clobetasol propionate 0.05%, start 2 days post-op and carry on for 5 days. So there are 4 intraoperative habits that reduce complications. Use conservative parameters, so in other words, least amount of energy possible. Do not be swayed by patients wanting you to go the strongest, okay? So it's really important. And at the end of the day, it's your reputation, it's your neck on the line. You need to take control, you need to take ownership, and you need to explain that effectively to the patient so that they understand. If they do not understand, you do not proceed with treatment. You can use adequate cooling in the treatment room. There is the Zimmer cooler. This reduces pain, reduces thermal injury, and also reduces the risk of post-inflammatory hyperpigmentation and scarring risk. If you're doing a fully ablative full face, you need to book in the sedationist who will prep the patient and come in and use IV sedation on the patient. They will completely own that, and it will allow you to perform the procedure in a much more comfortable environment for the patient and document everything: settings, passes, endpoint, what you saw, cooling method, and any intraoperative concerns. So let's go through your daily aftercare. Occlude with lanolin-free occlusive ointment such as petroleum jelly. If you're going fully ablative, I would go simple. Use petroleum jelly, Vaseline. Apply it to the entire treated area immediately after treatment. Cold compresses are very helpful. So there is the cold masks you can use, or reusable ice packs must be kept clean and never reapplied directly to the skin. But do avoid lanolin containing products because of the risk of irritation and allergy. I'm deliberately not mentioning the product brand names here. This is the basic consensus statement, ingredients and agents we should be using. In the first 7 to 14 days, you will see re-epithelialization occur. It's important the patient keeps the area moist at all times until crusting resolves. Soak multiple times a day with distilled water or dilute vinegar. And you can also use hypochlorous acid spray, which is Clinisept, and it comes in a spray format. Try not to use tap water to reduce infection risk, so they can use cool boiled water with some vinegar in it, and apply the Vaseline immediately after every soak. So important to avoid direct sun exposure. That includes sitting behind windows or at the window. They must not pick or scratch or traumatize the area. They must avoid retinoids, hydroxy acids and vitamin C for about 6 weeks. And again, limit contact with animals, hot tubs, steam rooms, other phones and gyms and crowds. Typically, the consensus says you're going to need petroleum for about 7 days. You can introduce a gentle facial cleanser from 2 to 3 days and a regular moisturizer from about 4 to 7 days. Healing takes a total of 4 months. So from 2 weeks through to month 4, the patient must continue with sun avoidance, daily sunscreen, gentle cleansers, moisturizers, and keep avoiding retinoids, acids, and vitamin C until you're happy their skin can tolerate it. That the earliest would be about 6 weeks. With fractional lasers, it might be 3 months for fully ablative lasers, full field lasers. The evidence shows that silicone-based creams, growth factor creams, hydrocolloid dressings, there's no consistent evidence, and there's no consistent evidence for using low-potency topical steroids for transient inflammation. I don't have a problem with any of you using this, but if we're going evidence-based, there is no consistent guideline. In a split-phase, triple-blinded, randomized controlled trial, the non-steroidal anti-inflammatory moisturizer MAS063DP performed comparably to triamcinolone for post-ablative healing. So it's a reasonable steroid-sparing option. However, 50% of cases still develop PIH despite an effective healing regimen. So it's important to tell your patients you have a 50% chance of developing post-inflammatory hyperpigmentation despite us putting them on a skin regimen. So the rate would be higher if it wasn't for the skin care regimen. So let's summarize. 6 things to take into your next case. First of all, antivirals for everybody, and I would advise valaciclovir 500 milligrams twice a day, 12 to 24 hours beforehand through till re-epithelialisation, so a 7 to 10 day course. Petroleum jelly, soaks with distilled water and vinegar, and after day 2 and 3 a gentle facial cleanser can be introduced. I would put antibiotic prophylaxis with everybody. I would start with doxycycline. Start that a day before the procedure, 2 tablets, so 200 milligrams, and then after that 1 tablet a day for 7 days. They must wear sun protection 4 weeks beforehand and for at least 4 to 6 months afterwards. And any persistent erythema or worsening pain or delayed healing, stop reassuring and start investigating. And here are the references.